Please start.
Hello, good evening, everyone. I welcome all our distinguished speakers and participants to the second masterclass of IFS SIG Poor Ovarian Reserve in collaboration with IFS Kerala and UP West chapter on understanding antral follicle count. And we are honored to have here a panel of distinguished speakers and who have contributed a lot in the field of IVF. As we embark on our today's webinar, first of all, I would like to have Dr. Shweta Mittal, ma'am.
I think Shweta is not here. So continue. Next.
Okay, ma'am. Then, ma'am, I'll invite Dr. KD Nair, sir, for the welcome address
Screen
to
share.
start the session.
This
Ma'am, correct.
Hello. Good evening, everyone. It's a pleasure for me to be inviting all of you to this webinar by SIG Poor Awareness Response. And today we have a very eminent speaker, a lovely friend of mine, Dr. Ashok Khurana, who is the lion of ultrasound in Delhi. And he is going to talk about the importance of antral follicle count in poor responder. Ashok Khurana.
Akanksha. Next.
Hello.
Yes, ma'am, but actually I didn't get his CV. Dr. Ashok Khurana, sir.
One second. Let me just thank the Kerala chapter and the UP West chapter for joining hands with us for this SIG. And I think this is one of the very important topics, antral follicle count. And today we are really going to thrash it out because we have a wonderful, very experienced speaker, Dr. Ashok Khurana, and I welcome him and all the delegates to the webinar.
Okay, so moving on to our session, I invite our chairpersons, Dr. KD Nair, sir, who is Senior Consultant, HOD, Akanksha IVF Center, New Delhi. And sir has got so many international awards to his name. And Dr. Ruchika Goyal.
Next.
Dr. Ruchika Goyal, she is Assistant Professor Consultant IVF, Good Life, Bareilly. And ma'am has got many international publications to her name.
Introduce Dr. Ashok.
Sir is a senior ultrasonologist with over 40 years of experience. I haven't got a CV, ma'am. Sorry.
So over to you, Ashok. Stop screen sharing. So would you like to call Dr. Ashok?
I think he's joined, huh? Adol.
Yeah, joined, but I think not with the speaker. The speaker sound is not showing. Just I'm checking with them.
Just call sir, no?
See, New Delhi. and our experienced panelists, Dr. Ubesh Jindal ma'am. She is Director Jindal IVF and Sant Memorial, Chandigarh. And ma'am has got so many national and international publications to her name. Dr. Nymphia Valecha, ma'am. She is Director Ops Gynae, Infertility Specialist at Fortis Shalimar Bagh. And she is also Executive Member of Fertility Preservation Society and has got various awards to her name. Dr. Professor Neeti Tiwari, ma'am. She is Senior Consultant at Gangaram Hospital and has got many papers to her name. Dr. Raju Nair, sir, Director and HOD, Mitra Hospital, Kerala. Sir has got many international and national publications to his name. We are starting with the panel discussion, ma'am.
Yeah. Just stop screen sharing. Yeah. Everybody can see the screen?
Yes, ma'am.
I have got
Okay.
Yes, sir.
connected in case you want me to start my, I know you've started with the
Oh.
panel, but I am now in good connectivity.
Okay, so we'll take yours first.
Can we?
Yeah. I'll stop screen.
Apologies for the inconvenience.
No problem.
Yes, Dr. Ashok. Welcome.
Sorry, I seem to have had lost my connectivity, but it's back again.
Okay.
May
Go
I
ahead.
share my screen?
Yes.
And are we able to see my screen nicely now? Is it?
Yes, sir.
Yes.
And I'm clearly heard and you can see my pointer, yes?
Yes, sir.
Yes. My apologies to everyone. Am I now clearly heard?
Yes, sir.
Excellent. Thank you very much for this invitation. And I am now looking forward to presenting before we start with the panel discussion on understanding antral follicle count. And the idea really is to find out what is the perspective of this particular aspect of testing as an ovarian reserve test. And so I'll take you through some of all of this so that we understand what is the background of this whole situation in terms of the theoretical aspects and in terms of the other ovarian reserve tests, and then a bit of technology and knobology so that everyone can learn how to do this on their own and the techniques to make it more accurate. And then I will, at the same time, go through mentioning the role of ultrasound in guiding management. So let's start right at the beginning. We do understand that we have several ways in which we can assess ovarian reserve. And we do understand today that the age of the patient perhaps remains really the single most important factor that we can talk about. The rest of them are things like the AMH, the antral follicle count, the ovarian volume on an ultrasound scan, ovarian stromal flow, and the estradiol on the day of HCG. But the question is, which should we use as the right test and when? We know that the AMH actually, as you see in my first illustration on the left side, will be a consequence of what is coming in from the small preantral follicles, the large preantral follicles, as well as the small antral follicles that are less than 10 millimeters, and then they would be reflected in the AMH. The antral follicle count would actually represent all the small antral follicles. The small and the large antral follicles put together would be contributing to inhibin B, which will then have a negative feedback on the FSH. And all of these put together, from the large preantral to the preovulatory follicles, would tell us about the estradiol. So in this situation, what really performs the best? We need a test at the beginning of a cycle, and therefore it makes no sense to think in terms of estradiol on the day of HCG. So that goes to the bottom of the list. Out of the rest of them, it's a question of where does AMH stand versus an antral follicle count. And AMH scores for the very simple reason that it does reflect the small and large preantral follicles. But we do understand one thing about AMH, and that is that because it's an assay, a lot of labs can use either good equipment or not so good equipment. A lot of them might not be using the exact kind of assay that is recommended by the statutory bodies. And therefore, what seems to actually perform very well is the antral follicle count. The other two ultrasound parameters, ovarian volume and ovarian stromal flow, are not such good performers. And so today I will go on to discuss the antral follicle count, and then at the perspective, of course, you understand already. It's very important to realize that you cannot do this on low-end equipment, and you can't do this by a transabdominal scan because it doesn't give you that kind of detail. What you would need is medium to high-end equipment, which fortunately in India today is much less expensive than we would have ever believed. The learning curve to actually demonstrate the antral follicle count is very, very short, and you learn it very fast. You need to do no more than 20 cases to be able to do a good antral follicle count. But do remember that the approach has to be transvaginal. In the odd patient that has never been sexually active and wants to freeze her eggs, you might use a transrectal approach, and at the time of picking up those ova, of course, give her the other options. When it comes to the transvaginal scans, we have to be a little careful in the equipment that we buy, because if you use the really low end, which is on the market, that's about 3 to 6 megahertz. It's not really good enough to give the kind of detail we're looking for to differentiate between one small follicle and the other small follicle. And therefore, we then understand that we would like to pick up at least a 5 to 9 megahertz. If we are a little more well-to-do, we could pick up a 6 to 12 or a mean 10 megahertz frequency. And all of these transvaginal scans really today should have a Doppler, and they should have a 3D, because the cost difference is not very much. So I want you to be aware of the fact that you can do high-end ultrasound scanning by not spending too much extra, by picking up a 3D with powered Doppler transvaginal transducer. Now, the price of that is not very much, and it can be used on a low-end machine, a medium-end machine, and a high-end machine. And the transducer is the same as long as the vendor is the same. So it's easy in your own practice then, without spending any extra money, to be able to carry out this bit of extra investigation very reliably and use it in a daily practice. The next question that we understand is that how do we get all these images, and is it easy to do? Please remember that the younger you are in your ultrasound practice, the more help you will need from the machine. And then you can't afford to have a machine that has 7 or 8 buttons to get to the point. So all good machines today, without charging anything extra, offer you what they call a touch screen, which is one single preset. And you press that one button and you get to see exactly what you wish to see. And that is something you should make sure that you have on your machine. And if you don't have it, call in the actual expert who knows about this, and then go right ahead. And then we say, all right, here is where we will go and do this particular test. When do we do an antral follicle count? Day 2 in treatment cycles, or in case you're starting on day 3 or day 4, you could stretch it till then. In purely diagnostic cycles, where you want to use it as one of the tests of ovarian reserve, you can do it anytime between day 2 to day 5. If you have a patient who's amenorrheic or severely oligomenoric for a long, long time, you can really do it anytime. But the important thing is that whenever you do it, you must scan the entire ovary, particularly if you find that you don't pick up any follicles in an ovary, which otherwise doesn't look too small. Look at one corner. You might find 1 or 2 follicles, which might be what you're looking for. And then you get back to this particular follicle and you try and focus a little better and see if you can pick it up. And then you'll know that you will have a lot of your answers. Please do remember that when you're doing this antral follicle count on day 2 or day 3 of your treatment cycle, if you do find a larger follicle or a residual follicle or a residual corpus luteum, which is more than 10 millimeters, then the scan should be repeated in the next cycle, because this would mess up the cycle a lot. These usually are associated with cycles that require much more gonadotrophin. The yield is much poorer, and very often the E2 levels go too high up, and you can't even think of putting back the embryos in the same cycle. So therefore, make sure that you do the antral follicle count, because otherwise, with that high level of E2 that they have in the beginning of their cycle, they might even have a lower antral follicle count. So all this adds up to tell me that I really need to be sensible about making sure that I have no larger cyst when I'm doing this. The usual technique is a 2D technique where you sweep across the ovary and try and pick up as much as you can. And then you say that, okay, I pick up one follicle here and one follicle here and some questionable follicles there. In a lot of ovaries where you have a lot of follicles, then the sweep takes place, but there are too many follicles for you to count. And in this case, then, you can either use a 2D automation, which is an expensive technique, or a cheaper technique, which is the 3D automation. And we will discuss this as we go along. But even on 2D, once you've done your counting, you count the number of 2 to 10 millimeter follicles. None of 10 millimeters are larger. If the count of the right and the left ovary put together is less than 5, that's called a low count. The high count, some people use a cutoff of 12, some use a cutoff of 20, just like they do for PCO, and some use it as a cutoff of 15. It doesn't matter which, because really speaking, a lot of our polycystic ovaries, which have been treated, or in a cycle where the ovaries have been downregulated, will anyway not have a high count, so you can never diagnose that bit. So really speaking, it's the low counts we're running after, the low reserve that we're looking for, and therefore you use a cutoff of right ovary plus left ovary less than 5. So the low amount of follicles will be 0, 1, 2, 3, and 4, adding up the left and the right. What's the great advantage of the antral follicle count? If you have a good antral follicle count, you will have a good number of mature follicles. Also, the number of oocytes retrieved from these follicles would be much higher than if you have a low count. The number of good embryos will also be higher in a better or normal antral follicle count compared to a low antral follicle count. Please also remember that protocol to be used in case of excess or low numbers would vary, and therefore this within the same cycle would form an excellent way of assessing whether you're going to use a large number to start with, a large amount of gonadotrophin to start with and then step down, or vice versa, or you're just going to treat them as poor ovarian reserve and use your personalized cycles. Also, if you have a fair decent number of antral follicles, you're going to get fewer cancelled cycles. And then you say, oh, this is nice, I can manage with these. Even in non-IVF cycles, the number of cycles which are successful would be much more with a decent antral follicle count. Moving on, it's wise, of course, to remember that you want to sweep from side to side. And before you finish off and call it quits on that particular patient for that morning, you will make sure that you also calculate the ovarian volume. And that means you focus the ovary at two planes at right angles to each other on 2D, draw one long axis, and on the other plane, you draw the two short axes, and you take half the length into width into thickness, and you will get ovarian volume, because it's a useful indicator in addition to the antral follicle count, although by itself, it's not a very sensitive indicator. Remember that if you have a larger cystic area, or if any follicle actually appears more ovoid, then it might be wiser to measure two diameters and take the average of both of them in order to make sure that all of these are less than 10 millimeters. And it's the same thing that you would follow during the stimulation of your cycle. So very often, if you have ovoid follicles, it's nice to take, because then some of the 10s might become a 10 into 7, in which case you don't have to postpone your antral follicle count to the next cycle. So ovoid follicles will need two dimensions rather than a single dimension of a single diameter. When you're going through all of these, please remember that there are some very simple steps to obtain the right image. One of them is magnification, and I will show you how you do it, which means you go from something where you had almost the ovary occupying only 1/3 of your image, compared to here where the ovary occupies more than 80% of your image. And notice how nicely you can actually see follicle delineation in a magnified image. There are two ways that magnification works. In fact, three ways. One is that you reduce depth and you exclude all this space. And I will show you a separate slide on this. The other is that you just magnify, which means you throw out the excess amount of ovary out of the image. The third way is you take a zoom window and you focus in, then the geometry of the entire equipment is being focused only on the area of interest. And that's when you get the best details, and that's when you get the most reliable measurements. So these three things about depth, zoom, and magnification should be used together, and we'll talk about them a little further. The next thing is the degree of blackness of the image can be changed by reducing a low system gain. That means the 2D gain should be less. And you notice that in the magnified version, the outline is nice and clean and the inside is nice and black. This is called low gain, and it really helps you to see much better. And it applies to smaller follicles, and it also applies to the not so small follicles as long as they're less than 10. Turn the gain down, you'll be able to get the outlines much better. So this one has a bit of echoes here. You turn the gain down, the gain down, and you can actually pick up the entire follicle nice and clearly. Remember also that sometimes we get stuck and we focus only one small part of the ovary, and that the nasty follicle that will spoil our readings would be lying on the periphery or the edge. So these are the technical considerations: the magnification or zoom, the low gain, and to sweep across the ovary in its entirety. When I talk about magnification, I said there were three things. One is that there is a depth knob, and you will usually find it on machines with this kind of an indication sitting right there. The one which shows an arrow at the bottom would mean that it would change and exclude all this area at the back. And then for magnification, you will exclude the areas on the side. But if you press zoom, you get a box on your window. And by activating that, you will actually get all the physics of that machine onto that area and get a nice clean image. So typically you should be first reducing the depth, go to the ovary that occupies almost the whole screen, then press in zoom, and then make sure that you get the kind of neat, clean picture. The second thing is this overall gain that I was mentioning. And again, look at the difference here. The gain button is usually the same as the 2D button. And in that situation, you say, all right, here I am, and I will now reduce the gain. And notice after reducing the gain, these follicles become nice and black so that you can pick up the edges and you can put your calipers on in the correct way. And that way you get a nice clean measurement, which is a more reliable measurement than in a fuzzy follicle. Most modern machines, like I mentioned, will integrate the overall gain in the 2D knob, and that is worth using. Now, once you've done all of this, then you will focus the right ovary, the left ovary on 2D and go on. Remember that essentially when you measure these follicles, a lot of the sophisticated machine might take you not to a simple measurement, but to a complicated measurement, such as individually for the uterus or the ovary and so on. Usually pressing the button again, the calculation button, will get you back to standard measurements. And then you go back to just measuring each follicle directly, and that's how you will get your answers. Remember that for putting on the measurements, sometimes on the really sophisticated machines, you just have to tap on it or take your arrow to it, or you could use a trackball and take it edge to edge and do your measurements. But always be patient and make sure that you measure each one of those follicles, never mind the total number. Yes, there will be ovaries that will have lots and lots of follicles. And then you know that none of us, honestly speaking, even in a down-regulated ovary, would have the patience to actually measure these things. In this case, we shift to a simple thing called 3D, which is not expensive. Most of this on a medium end machine would be available at no extra cost. Your transvaginal transducer would anyway be a 3D transvaginal transducer. You focus the ovary and you set it like focused over here, like I have shown, lots and lots of follicles. And then you press the button, which is called Sono AVC, and it sweeps through on its own, automated, and then gives you the follicles. If you find that it missed some follicles, like some occasional follicles in the higher part of the field, you just have to click on them and the machine automatically adds those. So you click and you add, and then you're able to get every one of these follicles, which otherwise, like in this situation where you have over 44 follicles, you would never actually have the patience to do. And these 44 follicles have to be compared to when you finish down regulating, and therefore it's not something that you can spend so much time on. None of us have that kind of time. So simple equipment which has a 3D function and this very readily available, inexpensive software, which usually comes free with the machine, can give you a very fast way of actually calculating the number of follicles. It also gives you the actual size of follicles. The newer equipment, which again is at the same cost, and you must realize that you will always ask for newer equipment, will magnify these automatically even more. And so then you can truly see that which ones will I be getting the multiple dimensions. The good thing is you don't have to measure the 2 or the 3 dimensions of each follicle. The equipment does it automatically, which means you press the button on activating the software and you get your answers. And this is what your report looks like. It's an automated generated report. Very, very useful when you have large numbers of follicles. The same software can be used also when you're doing your follicle monitoring. And notice here that on my right side, I was able to measure all the way up to 27 follicles. And on my left side also, I was able to measure all the way up to 13 follicles. In practice, you and me would never have the patience to actually do this. And therefore, I encourage you to make sure that you buy the right equipment that has similar software. And like I said, it is available at no extra cost. In the older versions, if you pick up, please do remember that before they could get a nice list like this one of all the follicles, and the newer equipment also identifies which is less than 4, which are between 4 and 7, which are between 7 and 10, and so on. You had many steps, and that was no good for you and me because, again, the same thing. We have patients that we have to see during the course of a morning. We have other things to do, and therefore we should get the computer to do it themselves. And therefore, we no longer have to do a simple 3D acquisition like you see in my top left image. This is done by the machine. You don't have to change the threshold for the black. That is set automatically by the machine. All you do is to hold the area of interest like you see here. You have a box around it that you have chosen. You press one button that says so, and you get a report like you're seeing here, and this will tell you exactly what is going on. So if you have a simple situation where you can count the follicles, you do that in 2D. If you have something like this, all you do is to make sure that you buy the correct equipment, that you press a single button, and you get these answers within seconds, and then your treatment protocol can be chosen accordingly. The advantage of looking at things like this, where you can differentiate, say, 30 or 40 follicles, is that automatically you know that I have to work much harder on down-regulating this ovary, and then you choose what you want. Or that I've reduced 44 follicles into 10 or 12, and I think this is the right time to now give my treatment protocol, and I will start on my stimulation protocol. So these large numbers will then need to be looked after accordingly. Remember that you can use it even when the follicles are not large. And once you get used to using this equipment, all you have to do is to press that one button and you get your answer very nicely. Even if the number of follicles was only 8 or 12, I still end up using this because it's just so easy to use this particular thing. So to fast track all your patients, to make sure you're making good use of your time, it's a very good idea to use an automated 3D follicle count in both ovaries. Of course, you will do it on the right, you will do it on the left, and even in women who don't have a large number of follicles. And look, for instance, here you have 11 follicles delineated on one side, you have 13 on the other side, and it's a very neat, clean idea. And you notice automatically that because the machine calculates the mean, as you see in the second last column, you don't even have to worry about which follicle to reject and which one not to. And therefore, this mean diameter will tell you, yes, okay, all follicles are there. There's a total of 24 follicles. They're all less than 10 millimeters. Great count. I might have to watch out for hyperstimulation. So I'll go a little soft and watch out whether I use HCG or LH for my trigger. And your whole cycle is planned out already. The tips for optimal use, let me repeat them. Ultrasound on day 2 or 3 of every treatment cycle. That's the best time to do the antral follicle count. Can you do it at any other time of the cycle? we do understand that a maturing follicle will suppress some of the antral follicles. And really speaking, therefore, before there is a selection of dominant follicles, you should do it in a cycle. And therefore, there's no question of doing an antral follicle count really in the second half of a treatment cycle or in planning future treatment cycles. Then, of course, you could use it when you want to do a rapid evaluation at a first patient visit, but you do understand that this would have limitations. You will note it in your notes and say, okay, perhaps I should repeat this on day 2 or 3. Remember that the new technology is cheaper than ever before, and you must make sure whether you can afford it, and then after you're affording it, you realize how much value it gives you for your time, and therefore it is worth possessing. And then the fourth aspect is that don't forget that some larger follicles might be at the periphery of the ovary, way to the side towards the lateral pelvic wall, and you must make sure that you include those as well. So what's the take to work message really from this talk that I've given you today? A, that this is easy to perform. B, that it's at no extra cost if you have a standard ultrasound machine that you use in your practice, because you would never use a low-end machine. The fact that you could also use AMH, but that goes into the world of unreliable laboratory work, which we say, okay, the proteomics doesn't work. The radiomics, which is the actual antral follicle count, and the new word for it, is something that is relatively inexpensive, easy to perform, gives you the results the same day, and is non-invasive. It's very, very reproducible because there's no big rocket science to producing these images, and it remains useful in improving IVF outcomes. And thank you so much for your attention. My apologies once again for not being available on time.
Thank you, Dr. Ashok. It was a wonderful lesson for all of us how to do about antral follicle count. And I'm very sure we're all enriched by your knowledge. What type of machine we should look into it and how to manipulate the machine for our daily use. I think that was excellent. Thank you very much. If somebody
A pleasure, sir.
Thank you, sir, for such an excellent talk. And it has been a learning experience to all the PGs, postgraduate students also, to how to maneuver the machines to do this most important yet basic test of antral follicle count, because all cycles will be monitored by our AFC, and if that goes wrong, the whole stimulation will go wrong. Thank you, sir, once again.
Thank you.
Over to Sarveen.
Okay, ma'am. Ma'am, we can't hear you.
Yeah. Hi. Okay. Thank you, Ashok. So we'll go on to the panel discussion. Everybody has been introduced. Raju's here, I think. Welcome, Raju.
Yeah, ma'am.
You have already been introduced. So without wasting time, I'll go on to the panel discussion. So the panel discussion is basically on applying antral follicle count in clinical practice. I welcome all the panelists along with my moderator, Dr. Renu Tanwar, Dr. Umesh Chindal, Nymphia, Neeti, Raju. Great to be on board. So I start with this case on, it's just a case-based discussion. So I'm not putting an introduction because we've heard so much from Ashok. So Mrs. A, a 24-year-old, had infertility.
Make it full screen. Will it be possible?
One sec. Is that okay? Everybody can see?
Yeah, ma'am. Thank you.
Husband is 29 years, infertility for 2 years. They've been trying. Day 2 FSS was 7.7, estradiol 30, AMH 2. Antral follicle on the right side was 1, on the left was 3. TVS showed a small endometrioma, 2 into 3 centimeters on the right side. Bilateral tubes patent, semen normal. 3 IUIs done, failed, probably for IVF this time. So, Neeti, do you feel this antral follicle count is accurate? And what do you depend more on in your clinical practice? Is it AFC or AMH?
So, ma'am, in this patient, this antral follicle count obviously is not corresponding to the AMH of 2 nanogram per ml. FSH of 7 international unit per ml on day 2, which is not corresponding. Maybe because of the presence of the endometrioma, the person who has seen the done the antral follicle count has not been able to see the antral follicle as
Yeah, very right. Yeah.
sir has just mentioned. And in my practice, if you ask me, I take both together. So not one parameter, I take AMH and AFC both together. And many a time we find a disparity between the two, and then we have to see, during the response how it responds.
Yeah, I agree with you because that's what I also do. Although literature is saying that antral follicle count is more accurate. And usually when I get a patient like this, I'd probably tell the patient, this is what I see. Although there may be more behind the endometrioma, we can't say. But yes, antral follicle, they say, has emerged as a primary predictor, but sometimes the AMH is more accurate.
I think,
Dr.
Suri,
Umesh?
one thing I would like to add here is that you may see this patient again at a different time to give you a,
Yes, ma'am.
Yeah.
because
That's-
many times it is cycle dependent, and in luteal phase, many times the antral follicle counts are not that clearly standing out, especially in presence of an endometrioma. So, I mean, it's not matching. One thing is very clear: AMH and AFC are not matching in this case.
Yeah.
But ultimately, the response actually depends on AFC. This is what I would say. But all limitations of all tests are there. So one repeat observation at a different phase of menstrual cycle perhaps will, reassure what
I
exactly
think
is the
another
AFC.
cycle. This is
Yeah.
day 2 AFC. This is day 2 AFC. So maybe another.
But ma'am, if
Maybe
she's
another
already
cycle, or
had,
maybe sometimes even in mid-cycle when the follicles, one follicle is developing, then they stand out. The other smaller ones are also stand out. So repeated observation might give you a better idea.
Yeah, like I always tell my patients that what you see is what is going to stimulate. I mean, if I'm
Yeah.
seeing 2 there, there's going to be 2 growing and nothing more.
and
Nimshi,
ma'am,
add a
yeah. Because ma'am, she already has had 3 cycles of IUI. We should be very sensitive about the stimulation. Sometimes, if the antral follicle count be better in the next cycle also, stimulating her, wasting her gonadotropins, and with so many IUIs, she might have had a cycle of OC pills or anything for endometrioma. We can take that history, but we can definitely, if she's a young girl, just 24. So we should give her that benefit of doubt and probably tell her to be on some antioxidants, and maybe we can see her AFC in the subsequent cycle before starting the stimulation. That can also be an option.
So, Nymphia, how would you counsel this patient? Like, what is the psychological impact of telling her that your antral
ma'am.
follicle?
Yes. So, ma'am, basically, we have to basically tell her that this is not matching. This can be one odd cycle. Now, once the patient has come for an IVF, they think it's the final thing. We cannot expect cancellation that is going to bother her more. So, if we counsel her with confidence that we believe that if the AMH is good, probably the subsequent cycle is going to have a better AFC and a better outcome, I'm sure she'll be convinced.
Yeah, so another thing is that in these cases, what the West is now doing is they're giving a multi-cycle approach. I'm not talking about dual stimulation, it's a multi-cycle approach that right in the beginning you tell the patient that you may need more than one cycle, whether you transfer in the
That's
first.
true. Right.
Then they are ready for a failure. That's one thing very important because many of the IVF centers just say that, okay, sure, let's go ahead with the IVF, ho jayega. But that's not true.
That's why, ma'am, we should not jump to the stimulation. Ki patient IS, so we just start the stimulation. So giving her a realistic approach, and she might ask what is the alternative. If it's not matching, then we can offer her that you might need 2 stimulations or try another cycle. I'm sure she should understand. She will.
So it
And
was decided. Yeah.
one thing I just wanted to point out here is that it is very important of who has done this ultrasound.
Yes,
We don't
that
have
was already pointed out. Yeah.
doing an antral follicle count for our patients, so it is very important. And sometimes it happens, especially in younger patients who have a good AMH, and suppose the AFC is looking very poor. On after 5 days of stimulation, when you call her, you find that there are other follicles also which are
Smaller follicles coming up.
so that is also very important.
And there's no harm in repeating it, like Dr. Umesh said,
Yeah.
to be doubly sure before you actually give her the sentence.
Right.
So it was decided to take up this patient for IVF with an antagonist cycle and a recombinant FSH 225. In the cycle for IVF, the day 2 scan showed 10, 10, 3, and 3. So why should this happen? Can you prevent it, and how would you continue this cycle? Raju, are you there?
Yeah, yeah, actually, this particular patient has got a disparity in AMH and AFC. So the data scan showing an asynchronous follicle size. So some
Yes.
follicles are very small and some are big. So the problem is their responsiveness or the FSH responsiveness might have started in the late luteal phase. So some of one or two follicles has grown a little bigger and other follicles are subnormal. So the problem with this type of patients is that when we start stimulating with the gonadotropin, the bigger ones start growing, the other one can get suppressed. So we'll get an absolutely asynchronous cohort, and your usage yield will be low. So that is what usually happens with this sort of FC.
So, how do you prevent this? Is there any
Yeah,
manner
first,
in which maybe you would prevent it if you had known this would occur, or maybe the
yeah,
next?
basically in our patient, since she's a 25-year-old girl with an AMH of 2 and AFC of 3, obviously there is a disparity between these two. So intracycle variations and that error of AMH to be looked into. So obviously in that scenario, I'll like to repeat the possibility of an intracycle variability, repeat the AMH, and suppose the status quo is similar. We have to redefine her as a poor responder, not that unexplained poor responder. She will be a poor responder. So in that poor responder patient, maybe a follicular synchronization with an E2 priming, estrogen priming, all definitely will help you in getting a synchronized follicle cohort so that your oocyte growth will be synchronized.
Yeah. So, what are the options? And Dr. Umesh, here, may I ask you what you do on these patients?
Yeah, I think if I see the discordance on the very first day, I mean, it's this cycle is destined to have a discordant follicular cohort. So I would like to synchronize this.
So, how do you do it? There is the agonist, and there is estradiol, and there's the antagonist. So, what is your preference in
I
synchronize?
think I'm getting in love with the elagolix.
Okay, so what's your experience? Let's hear elagolix. What's your experience with elagolix?
I think it's you are getting down regulation without actually long-term down regulation. The
When you start, how much?
basic advantage is the quick recovery.
Yeah.
But
So,
definitely, if you downregulate, your LH is going down, your E2 is
yeah,
going down.
absolutely.
So
Yeah.
all those side effects of downregulation also would be there. But
Yeah.
I still prefer elagolix over agonists, Dupride or anything.
So,
The
what is
recovery
your
part is.
regime? Yeah, what is your regime? When do you start? How much dose do you give? And when do you stop?
See, actually, this is only a very preliminary impression, I would say.
Yeah.
Not data as such, we can say. But I usually empirically give 150 milligram twice a day for 10 days at least.
For
10 days at least.
10 days. So you start on day 21? How do you?
Yeah, 7 to 10 days. Yeah.
21. Day 21, you start till period.
Yeah. And then give a 2 days or 3 days washout period for LH and FSH to recover a little bit.
And then you start the stimulation.
You get a beautiful, synchronized cohort.
Okay. Anyone else? Nymphia, Neeti, anything you want to say on this topic?
Particularly, I was just concerned that though she had a reasonable AMH, but the AFC was low. So 225 was a little lower dose of gonadotropin. If we are seeing a lower AFC, because we are stimulating and deciding the dose according to the antral follicle count.
Yeah. So how much
Then,
would you use?
at least an FSH of 300.
300.
And I have an inclination of adding an LH in case of if I'm seeing a lower antifollicular count. I feel it gives, no, it's a recommendation. It gives a better
So
response.
you start the LH on day 1?
Yes, ma'am. Generally, the recommended FSH and LH combination.
Even in young patients?
It will be because if we are starting, it will be, of course, it's a poor responder. So the poor responder recommendation would be adding an
It's a
LH.
poor ovarian reserve.
Ovarian reserve, sorry, not the responder. It's a poor ovarian reserve. Comes into the Poseidon criteria, yes.
Neeti, would you like to comment on your
absolutely.
protocol?
I agree with Nymphia that I would have also started with 300 unit, because when I say that I depend both on AMH and AFC for deciding my dose, if the AFC I'm seeing on the lower side, I will always go for the highest dose. And for me, the highest dose is 300 unit. I would have started that. Another thing I was thinking was that in this patient, she had two follicles which were just, reaching 10 mm,
Yeah.
not beyond 10 mm. I would have seen her estradiol level. And if the estradiol level would have been less, like say less
It
than
was
70,
30. Estradiol was 30 in this patient.
estradiol level 30 on day 2 with two follicles which are 10 mm, I would have gone ahead with the stimulation. I wouldn't have thought
On
of
ahead.
down
I
regulating.
just want to know, would anybody cancel this
No,
stimulation?
I would never. And I would have gone ahead and I would have not thought of if with the estradiol level of 30 with two follicles which are reaching 10 mm, which is the highest thing for antral
Yeah.
follicle count. I wouldn't have thought of down regulation, nothing. I would have gone ahead with the stimulation.
So, what is the cutoff for not stimulating the estradiol level? Like, what would you, if this patient had a estradiol of what would you say, "Okay, I will not stimulate"?
Ma'am, usually I take a cutoff of 75
Okay.
and
All right.
above that. And if I feel there is a follicle 14, 15 mm sitting there and a E2 of say 100 or something like that, then I would have thought of. With a E2 of 30 and two follicles reaching 10 mm, I would have gone ahead with the stimulation.
Dr. Umesh, your experience on the protocol, dose, etc. Anybody using minimal stimulation?
I think in this patient, minimal stimulation works very well. You don't have to increase the dose because there are two follicles, they only two will come, whatever you give. So even clomiphene will work here.
Do you use
Clomiphene
only
plus gonadotropins.
clomiphene or do you use it with gonadotropins?
No, clomiphene plus gonadotropins.
Plus gonadotropins. And Raju, do you differ in any manner to?
I would like to be a little more conservative in approach. So I may not start the simulation at all because unless the patient is that much hard pressed to move on with an IVF, because as rightly pointed out, the IVF will give you a lot of hope to the patient as well as to the doctor. So if you see that the response is not going to be brighter, why can't we take a break and reassess the patient and do a simulation maybe one or two cycles later? Because her age is less, she has a very small endometrioma. The duration of marriage is not very high. So why to haste yourself to and get into some trouble? So a little bit of conservative approach, counseling with the patient will sometimes help. And if we get time, obviously we can give some adjuvants before stimulation because
So you would delay her stimulation, give her adjuvants,
probably
make
because
her.
considering her age and other parameters, I don't think there's nothing much to
Do you
hurry
think
on unless
it will make a difference
sometimes, madam.
in your practice? It makes a
Yeah,
difference?
very much, very
Okay.
much.
All right.
Sureen, since we know that there is AFC is low, I will
Yeah.
not decide this on the day of stimulation. I will decide on day 21 what I'm planning to do.
What you're planning to do.
Yeah.
Okay. But this patient came to came from another center and she was already kind of stimulated. She was already, the cycle was done. So day 5, we find that there's 116, 110, 10, and 8. What changes can be brought in gonadotropins being given? Do you want to increase dose, decrease dose? Increase, we've already said. Do you want to add something in a gonadotropin, and any new protocol you could think of for a poor responder, and any add-ons? So, Dr. Umesh, would you like to take this?
Add-ons at this stage would not help. You increase the dose, you will just push this 16 mm follicle further.
Okay, so you
Practically,
the same
I will
dose.
either I will go with a single follicle, discuss with the patient. There are many patients who would still continue with even a single follicle.
Yeah.
So otherwise, I will drop this cycle again. Down regulate this and then go for it.
And what about adding LH? Would you add LH at this time when you're seeing some follicles which are 10 mm?
It's basically discordance. It's not that the follicles are not growing. The dominant follicle is 16 mm.
Yeah.
It is day 5.
Yeah.
So it is outpaced the others.
Okay.
So LH, obviously we give in poor responders. We practically give to LH to all patients on day 5. That is not the question, but I don't think that's going to rescue these smaller follicles.
What about Raju? Anything from your end?
Yeah, ma'am. I have a difference of opinion in this scenario because we have one follicle 16 and other three are in the same cohort, 10, 10, and 8. So my approach will be just forfeit that 16 and try to push that remaining three to come up. So I may give some progesterone or antagonist something to suppress the LH so that the 16 will be eliminated. Other follicles with the gonadotropins may or may not grow. So it will get a definitely better than maybe 3 or 4 follicles compared with one odd follicle.
Yeah, that's what I do because I chuck off the one which is getting large for the sake of getting the smaller ones in. Neeti and yeah.
So, ma'am,
Nymphia, anything you
I
want add-ons, May?
I
LH.
would antagonist. I will add from this day 5, and I would also wait for the other two also to grow. And we know now that even if the follicle reaches 12 size, we'll be able to get oocytes from them. So I don't think so. We will lose the bigger one also, and we will have 3 follicles if we, go ahead.
Like in this patient, we gave just a 225 FSH, so I'm sure LH would help, and it
Yeah.
does help in clinical practice.
It does help. I agree. You see them, they start growing immediately. But what about counseling her on dual stimulation? Would you do it or not do it?
Ma'am, dual stimulation again depends upon the day when I do the OCR. If I find some antral follicle there, if I find that there are smaller follicles still there in the ovary, and if I give a further stimulation, she will grow further, then I can consider dual stimulation definitely. But now, we are doing a lot of biostimulation also. So biostim is another thing which we are doing, and we find good results with biostim. So if the patient, especially because when we are doing dual stimulation, we know that it is another 2 days extra of stimulation. So patient should be ready.
Yeah.
If
The
she has
longer.
taken, yeah, so if she has taken 10 days of gonadotropin in follicular phase, she will require 12, 13 days in, and sometimes
More than that sometimes. More than that.
so it becomes hectic sometimes for the patient. So biostimulation can also be done.
Anybody using growth hormone?
I'd
Any,
used it long back, but not now.
Yeah.
anyone? Dr.
Yes.
Umesh?
Same here. I also used growth hormone long back, but not at this stage. If I have to use growth hormone, I will
From the
use it
beginning.
from the very beginning.
No, Acha. So I want to quote my experience. It
Okay.
works wonderfully at this stage. Supposing you got to know these are not growing, and you start the growth hormone, they actually come up beautifully. And sometimes even very small ones, you can see them growing. So that's been my experience, and I'm using it regularly. And
What are you giving, ma'am? 4 units.
four. And this discordant growth may especially, you just see them coming up so nicely that they'll be about 14 when you're doing the pickup. 14, 15 is what you get.
Okay.
Yeah, I've seen a very good response. And this has been my personal experience with nearly all the patients I've started the growth hormone.
Okay, ma'am. Can be tried, yeah.
What about DHEA? Well, in the next cycle, not this cycle, or testosterone, anybody using it for these kind of patients?
As a pre-treatment, madam. Yeah.
Huh?
Not in the index cycle, as a pre-treatment, definitely.
Pre-treatment, you're using it. What
Yeah.
are you using, DHEA or testosterone?
I'll try both. Testosterone is a gel form, around 14 days prior to the next period.
Yeah.
And DHEA, if the patient is already confirmed as a poor responder, we put them on the DHEA for close to 3 months, 75 milligrams.
Anybody who's not using it, like definitely not using it, like they don't feel that it should be used at all? Any?
We are using, but we all know that it may not work.
And
Yeah.
ma'am, in younger poor responders, now we really
Yeah, it's
but
probably
in
not.
poor
Yeah.
responders, they may not help.
This patient is 24, so it may not help. It's the 35 and above where it helps more.
Yeah.
Yeah. But although Cochrane has said that testosterone improves the
What
outcome.
I feel is that the antral follicle count may differ, it may vary a lot in such young patients. Next
Yeah.
time we may find a better antral follicle count only, and she might not even need anything else.
Yeah. So on day 9, she had 22, 18, 12, 11. What are the implications of triggering in these follicle sizes? And when would you like to trigger? Would you like to wait? I think Raju has answered to some extent, but I'd like to know, Neeti, what is your take on it?
I will trigger at this point, ma'am, because otherwise I will lose this 22-18.
Nymphia?
Trigger, madam.
And Mesh? Dr. Umesh, are you there?
What did we get?
I think the smaller follicles don't yield much. Although literature mentions it, but they don't yield much.
Yeah, so literature mentions it, but it has been my experience also that the smaller follicles yield. I did a thesis, and in that, smaller follicles have yielded and gone to blast, and so have the larger
Mature
ones.
also, ma'am, and they are mature also.
They're mature. They're mature. They give you blast. Of course, less than what an optimum size would give. And the larger follicles of 24, 25 also yield. I actually make the 22 go to 24 and make the rest +2, and then I trigger. That is my experience, although probably it's not written in any book. And what Neeti and Dr. Umesh and everybody is saying is right, that you do kind of trigger at this time. Raju, any comment on your side, from your side on this triggering?
But in my experience, when the follicle sizes say crosses 20 to 23, I hardly get oocytes in that because say around 16 onwards, the oocyte, mature oocyte will be there.
Recovery
But
is
the
less.
follicle size is more than say 20 to 23. I usually get just follicular fluid, nothing much.
You can see recovery is less in this stage. But definitely. Okay, now would you convert this to an IUI cycle or continue IVF, and should you abandon the cycle? Like Raju said that Raju, would you abandon it? You said earlier you won't start, but if you're at this stage, would you abandon or?
The patient might have spent so much money for it, so definitely try your luck.
So you would carry on with an IUI or an IVF?
No, if the patient is keen, I'll definitely give a dual trigger and do the pickup.
Nymphia?
Once the patient was already counseled.
Yeah.
That so we have reached a reasonable response to what we had counseled. So now, after so many days of stimulation, we should go ahead. The
Dr.
patient is prepared for it.
Yeah, Dr. Umesh?
Yeah, same here. No IOIs. No,
Neeti
don't
same?
convert to IOI now.
Neeti same?
Yeah, ma'am. But just counseling on the day, final trigger day, we
Yeah,
tell
yeah.
her so that we get a
Yeah.
shock of your
Yeah.
OCR.
Even the literature says that if you've got two good follicles, go ahead with IVF because your results are much better compared.
I'm sure everyone has had pregnancies with 2 follicles,
Yes,
one
yes.
And
embryo.
ma'am,
Everybody has.
she has 3 failed IUI and underlying endometriosis. We
Yeah.
don't even know what is the pelvic factor inside.
Yes.
And 3 failed IUI cycles, we should go ahead.
Right. So there were 2 oocytes retrieved, both first fertilized, 1 blast, 3 AA.
Wow.
So what is FORT and FOI? This is my last question because I felt I should put it here. Anybody wants to take it?
So
Raju?
FOD is basically from antral follicle to the mature follicle count. And follicle to oocyte index is basically the more practical one from the antral follicle to the retrieved oocytes.
Yeah, absolutely. And what is hypo in these, that you find it's a low response? Where do you act?
When it is less than 50% has been.
Yeah. So our patient was at 50%, and well, it was, I would say it was low, whatever. So over to you'll screen share, right, Renu? 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 You're on mute.
Yeah, got it. Should I share now?
Yeah, please. Thank you, everybody.
Can you see my screen?
Yeah.
Yeah.
Okay. So good evening to all. And I was hearing all the discussions. I think it was a great discussion. Now, one thing was very good about this patient, that your patient was young, Surveen. So I just felt on telling that this patient is young and we should go ahead. Anyway, you took the discussion very good. Okay, so I have, so I'm going to talk about high FC count. So Surveen took the low FC count, and I'm going to talk about the high FC count. My screen is not moving.
Make it full screen, Dr. Renu. Make it full screen and try.
I think it's full screen.
No, it is not full screen for us.
Right, sure.
Is it all right now?
Yeah.
Okay. So we have another patient who's 30 years old, married for 7 years, and she's unable to conceive since 7 years. A day 2 scan was done, and it showed both ovaries were multicystic. Now, treatment history was that she had already taken 4 cycles of ovulation induction and that had failed. Now the patient wanted an IVF. So the questions are for all the panelists, how do you, one by one, I think everyone can answer, how do you define increased antral follicle count in your clinical practice? What is the cutoff for you all? Neeti, we can start with you.
So, Dr. Renu, we are doing a very basic scan on not the Sono AVC, which Dr. Khurana was talking about. So, if I find, more than 10 follicles on both sides, like 10 on one side, 10 on other side, so basically 20, I think it is an increased antral follicle count in my practice.
Okay. So, Dr. Raju, what about you? What do you
Yeah,
do?
same, madam. It's around 10 to 12 follicles. I'm very happy with it.
Okay. Umesh, madam?
We always follow the guidelines. The
Hmm.
guidelines now say that the definition of polycystic ovaries, if there are more than 10 follicles in any cut section. So
Yeah.
20 in, I think, the whole ovary, which we are not doing that way routinely. So I think I agree with the previous speakers that more than 10, if one cut section you see, then you label this as polycystic ovaries.
So anything like 20, right? Total antral follicle, 10 in one ovary, 10. So you are taking 20 as a Nymphia. Nymphia, what about any smaller number you want to talk, or you also want to say 20?
No, not smaller numbers. So around 8 to 24, 24 in both the ovaries is an average, and anything above that is an high count. So basically, you
Yeah.
get the feel. As Dr. Neeti said, most of us are doing basic scans because Sono
Yeah.
AVC is also hypersensitive. It also has an error rate of counting a higher rate, which might not be there. So I think we trust more on our regular scan done in two.
Yeah, I do agree with all the panelists. In fact, everybody is doing a 2D ultrasound unless some other ultrasonologists are there who are using the Sono AVC. I think majority are doing with 2D. I don't think so majority are doing 3D or what. And I think so that's a rough idea. When we sweep whole of the ovary and we see that we are more than 10 to 12 in one ovary, maybe you think that it's going to be hyper response. So let me see what the literature said. This was a study which was done in 2018, counting antral follicle count by ultrasound. And they also said that different techniques have been used. Is it a 3D real-time 2D ultrasound or a 3D ultrasound or Sono AVC? And there are advantages and disadvantages to each of them. So basically, let us come to the practical point. Yes, we are doing a 2D ultrasound, and that whatever you all said was absolutely correct. The PGs can go through the different advantages and disadvantages regarding each of them. That is why I put the screen for them. And they also said that if you want to do an ultrasound, maybe a transvaginal ultrasound more than 7 megahertz, and I think that what Dr. Ashok Khurana also said. And he said minimum 20 to 45 supervised examination, then only you can become an expert regarding to count on the AFCs. This is the minimum number of examination to be done by the new beginner. And obviously there was no strong evidence that anything was better than the other. And it all depends upon the experience, the machine which you're talking about, and even the megahertz machine you're using. So that was the end result of all that. Then regarding the number of count, which they said was that another study, they said multifollicular high antral follicle count, when you see the follicular number per ovary, more than 25. But they said that anything more than or equal to 20 was a high risk of ovarian response. So that we all agree to that. Then this is another latest study which has been published in 2025, and they wanted to find out whether the AMH or the antral follicle count, is there any threshold where we can say it is a hyper response. So I just took out this study because it was latest. And they also said this was a retrospective multi-center cohort study, and it has been published in 2025. They had taken 4,220 patients, out of which 2,132 were hyper responders. And then they did an ROC curve for that. And they said that the cutoff for thresholds for hyper response was AMH more than 4.38 nanogram if the patient age was less than 35, and AFC should be more than 16 for a patient who was less than 35. And for the patient who was more than 35 or equal to, say that AMH level 4.9 nanograms and AFC count was more than 18. So that is how they had given this inference, and they calculated this threshold. So it is more than 16 or more than 18 depending upon the age. So this was a very nice study which they had taken out. So this was an ROC curve, and this was not a comparison, but if you see on this here, if you see the area under the curve for the AMH as well as this thing, for the age less than 35, just see it is 0.6, and for antral follicle count is 0.76. I think AFC fares better also because the area under the curve is higher in this. and it is 0.8. So it is less than 35, more than 35. On the left hand side of mine is less than 35 for the AMH and AFC, and on the right hand of this thing is the area under the curve where the patient is more than 35 and the area of curve was 0.8. So higher in the AFC count, whether you take less than age or more than 35 years. So even this was another study which was published in 23, that is the hyper response risk assessment. This was a Delphi consensus. This was done in 23. They also said the lowest AFC count that could place a patient for hyper response was more than or equal to 18. And they could not, there was no consensus regarding the number of growing follicles more than 10 that could define the hyper response. And even ASRM guideline says AFC more than or equal to 24 could be high risk for OHS. NICE guideline also keeps to more than 16. And even the International Committee for Monitoring Assisted Reproductive Technique also said more than 20 follicles. So they are nearly on the same page. Everybody's on the same page. So now this next question is, how do you decide the starting dose of gonadotropin in patient with high FC count in your clinical practice? Umesh, madam, can I take this answer from you?
Yeah, I
How
think,
do you decide, madam?
yeah, it's always a difficult decision and
Yeah,
double-edged sword. If you start
yes.
with the lower dose, response may not be there, and if you start with the higher dose, it would be hyper. And incremental doses are also risky. So the
Yeah.
guide in such a case would be age, which is in this patient, she is young. And the other would be if you have any history of previous response. I think she did have IUI cycles, so some idea
Yes.
you will get that how many follicles were developing from there. So the starting dose, and the third would be weight. You'll take weight into
The BMI.
BMI. So
Okay.
you will start with either 150 or 225.
So that's your range whenever you start, madam. Follicle and FSH, obviously, if you want to.
Yes.
Recombinant FSH.
Yeah, yeah.
Okay. Okay. Nymphia, what about you?
And if basal FSH is high, I mean, then in this patient, sometimes FSH is the guide. If basal FSH is high, high means 8, 9, 10 or something, then she may be one of those who has receptor polymorphism. And little higher dose may be required in these patients.
So, ma'am, on day 2, you take the FSH, you take the AMH, you take the AFC, you take the age, you take the BMI.
No,
That's it.
not in the same cycle. You may have
Okay.
done it earlier also. So
So
it's
you
not,
just correlate the things and decide.
yeah, correlate this.
Okay. Okay, ma'am. Nymphia, what about you?
Rightly said, besides the AFC, the age, AMH, BMI, and previous response is important. But the higher responders, even the PCO, you can have a different ovarian look. Sometimes it's just you see 20 to 24 oocytes in both ovaries, and sometimes it can be more than that. So then the dose varies. So in a very, when we have those honeycomb ovaries, the dose will vary somewhere between 150 to 175 for me. But in a PCO where the AFC is around 2024, a maximum dose of 200 after
Okay.
considering rest of the factors. Yes.
Raju, what about you?
Same, ma'am. The BMI and the previous response, if we have that, definitely. Because as Ms. Madam rightly pointed out, if we say starting with a very low dose, we sometimes end up in no response at all. So the minimal
Yeah.
dose would be 150 and to extend maximum up to 235.
Okay. Niti, where are you? You
Yeah,
not answer the
here
first.
only.
Yeah, please. Please chip
So,
in.
the dose for this patient, if she's a normal BMI, will fall between 150 to 225, as Dr. Umesh said. And I agree with ma'am that we have a practice of doing a baseline FSH-LH on the start of the cycle. We have this practice for years now. And it is not only the baseline FSH, even the FSH-LH ratio. So if you find that there is a FSH of 8 and the LH is say 4 or 5, as in LH is lower than FSH, this patient might also respond poorly, though her AFC might be looking very good. So there are a lot of things which you can, correlate. And of course, the BMI is important and her previous response. So it will be somewhere between 150 to 225. One thing I wanted to mention is that sometimes when the AMH is very high, say more than 10 nanogram per ml, these women may not respond to the smaller doses, especially when the AMH is very high. So in such cases also we have to be careful. By starting on a low dose, we might end up with, a very poor response. So
So I do agree with you, Neeti, and all the panelists, I do agree. I think we have to take a somewhat like a mixed picture. I'll tell you,
Yeah.
Neeti, what you were talking, even Madam was talking, at times they don't respond. That is the resistant ovary syndrome.
Yeah.
I
Yeah.
told you that. I think I had a lecture last year. I told about the AMH, where the AMH will be normal. The FC count will also be
Higher
high.
side, AMH may be on the
Yes, they
higher
are the
side.
resistant ovary, but their FSH will be very high. That is how you differentiate between the normal PCO and the resistant ovary, where the FSH will be also high in these kind of patients. So those
Yeah.
are the patients where you have to think for a higher dose at times.
Higher dose.
So
But
that's how you
anyway,
differentiate.
anything will not start go beyond 225. So it has to be between 150 to 225 in this case.
Yeah, yeah. So they are very tricky patients. So this is message for all of them. You have to really see what you're seeing on the ultrasound. You match the things. It's not that every time you have to get the FSH. Maybe once a time she has got it and just have an idea. Even by looking at the ovary, when you see there's a lot of stroma, that means these patients are also who are going to be difficult to treat, at times. So
Yeah, the
treatment
distance.
regarding this was a study which was done in 2023 regarding the treatment algorithms for high responders. And this was the treatment strategy which we are all doing. I think there's nothing new to tell you, because they also said that you have to start according to ovarian reserves and normograms. Antagonist protocol is all there. Stimulated strategies was that they have discussed that you should freeze all, and then you trigger, you have to go with the GnRH agonist trigger, definitely. If you want to go for antag, maybe the low dose HC, but I don't think so. I don't want to give that message. I think agonist is better, and freeze all policy is always there, right? And nothing new that they could tell regarding this. Regarding individualized versus standard FSS dosing in women starting IFS, IVF and ICSI, this was a randomized controlled trial for a hyper-responder. And then they had taken, study was done somewhere in 2011 to 14, where the AFC was more than 15. And they had taken the dose of 100 and 150. They had compared these two patients. The number of patients were nearly equal. And what they found that the cumulative live birth were nearly similar in both of them. So that doesn't affect much. But yes, the occurrence of any grade of OHS was lesser in the lesser dose, that we all know. So nothing much.
They all
So it
must be
was the
normal.
cumulative live birth remained same. Yes, Neeti wanted to say something?
They all must have been normal BMI because
Yeah,
for a
that
high
is where.
BMI,
This is regarding the AFC count they had taken and then taken this thing. And regarding the nomograms, this was been published again in 2023 regarding the dose for polycystic ovarian syndrome. And again, this is a beautiful chart. We can also, I think we can make it and then become much wiser whether we are really giving the right dose on. At times we just think it. I think we can also chart and correlate whether this is, I think it works well. If you have the BMI, the basal FSH, the basal LH, the AMH, AFC, and this is how they had taken everything. And this is published in this 23 paper. All the PGs can see the nomograph regarding the initial FSH dose that can be taken out, because they have taken all the things together. And obviously individualization of FS starting dose, that has to be taken account. And again, this is the similar where they have taken the age, the AFC, the FSH they have taken. Even this is fair enough. So any of these nomograms, there are many nomograms, we can put them in front of our ultrasound machines, and maybe the PGs can learn that way. And antral follicle count we are all seeing, and this was a systematic review which was done from 2002 to 2015. And they also said that they had all taken the AFC count, and that those were somewhere between 150 maximum 300 they have also taken. And they had seen that the severe OHS, they had just seen that the pregnancy rate ranged somewhere between 28 to 31%. Again, this was a similar study, and there was very different. So similar things were told in this. And regarding this, they had done the individualized rate as well as the standard dose. The standard was 150, and individual they taken from 450 to 25. Everything was this thing. And then they had compared the study. They made a contrarian for the FC count. Here, the FC more than 15 was a hyper responder. And they also said that the individualized starting dose was more expensive. Obviously, you're giving a higher dose at times. And individualized dosing reduced the occurrence of severe to moderate OHS. Obviously, we know when the dose is less, at times that will be there. Again, a nomogram. This is a newer one which has come up. It is simpler, I thought, so I just put it for everybody. The BMI, the AMH, the FC. Then you take out the total points, and then you draw a line downwards. If it is 20 pounds, draw a line downward, and then you can see the starting dose of gonadotropin. So there are so many different things which are coming up. You can just see which one suits for you all. So can I just ask Neeti, does the dose of gonadotropin impact the clinical pregnancy rate, live birth rate, and OHS? Anything you think higher dose I will give, maybe the pregnancy rate will better, the number
We
of.
always try to stimulate, the idea is to get up to 15 oocytes. This is what we plan. But of course, in a hyper responder, it might be difficult. But it is not like, we want to get as many eggs as possible. We don't do that. But now, in hyper responders, we fail sometimes, despite, as ma'am also said, Dr. Umesh, that it is very difficult to decide the dose. We think it is a normal this thing, and she might end up with 30-35 oocytes, which we don't want. We have seen that now that, even with that number, we might be able to get good number of blastocyst and good live birth. A lot of studies have come up that it is not that you have no more number of oocytes, so it will impact your in a negative way your live birth rate or anything. So in our practice, we try to keep it up to 15 oocytes if possible.
Yeah. Nivya, what about you? Are also targeting 15 every time?
Yes. So dose does affect because more is not better. It's not
I
that
know.
so individualized dosing is important because lesser will be lead to suboptimal development, poor oocyte yield. And so optimum is 8 to 15 because that will give us the best endometrial receptivity, the good embryo quality, and best live birth rates. So this is the target, 8 to 15, as Dr. Neeti said.
So Raju, your target is also similar, 15?
Yeah, I think obviously because the policy is once and done because the simulation goes once, like good oocytes and cumulative pregnancy should be better. But one point to be highlighted is the dose of gonadotropin. Suppose we obviously give more of gonadotropins, especially with hyperresponders, usually the oocyte quality goes down because a
Yeah,
lot of perivitline space debris, vacuolations, all sort of things are much more common. So the optimal dosing is very important for the better quality oocyte. So that's one point I
definitely,
like to highlight.
definitely. Ma'am, Umesh ma'am, I just wanted to ask you here, do you add LH always in these patients or do you just take for the FSH only? What about you? Do you do on the day 6? Do you usually add or you think about and then add? What is your practice,
We are
madam?
usually adding on day 5.
Day 5 you add, not on day 6, ma'am?
5, 6 will be in
5,
mix.
6.
We usually add.
Okay. So that is, if you have started with 225 FSH, do you add LH more or you just convert it into HMG? What is your practice routine?
No, add HMG, I would say, or
So you just
replace.
convert it into, if the dose is same, your starting dose, you depending upon the follicles which have you just change it to HMG. You don't add more of LH right now.
I mean, I see it's a flexible thing. You individualize in every patient, depending
Yes.
upon what you want. If it's already a hyper, then you may replace recombinant with HMG, or it's a kind of stable response. You may add some HMG, or maybe partially replace. You retain some of the recombinant and partially replace it with HMG. So all sorts of flexibilities. Yeah.
Okay, ma'am. What about you, Niti? Do you continue with the recombinant LH the whole of the cycle? Do you think?
I
What
only
is your take?
I only continue with recombinant FSH in such patients,
Yeah.
30-year-old, a hyperresponder 30-year-old. I will not think of adding LH.
See, recombinant LH is not available now. So we have, if we add LH, we are adding HMG only practically.
Yeah, I got it, ma'am, because that's too costly. Even in government work setup, we don't have a recombinant LH at all.
Yeah,
So that is
available
what I was.
cost. Besides cost, it's not available. You can't.
Yes, I know. Niti, how do you decide that I will straight away go for the same recombinant FSH and I don't want to need LH? How do you decide that on day 6?
See, in a hyper responder patient, like this patient of yours, 30-year-old, I expect a normal response to come up after 5 days. So why should I think of, adding LH? I don't usually do that. And in fact, if I suppose I have started with a higher dose, whatever dose I have decided, and I find that the E2 has gone really high after 5 days, even I think of reducing the FSH dose a bit after 5 days.
How much? 50, 12? How much do you
Yeah, so
think?
suppose I have started with 225 and I find that the E2 has gone haywire after 5 days of this thing, more than 1500 or something, and there are a lot of follicles coming up. I might reduce by 50, 75 units. Yeah, I do that on the when I add antagonist.
So you start the antag and then reduce the dose as well.
Yeah, I do that. If
Do
I
you
find that
consider
E2 has
taking LH values on day 2 on these kind of patients? Do you consider that? Whether you want to add LH on day 6 or not?
No, I don't see it. Anyway, the LH values don't have to be seen for adding LH in a hyper responder, or even for that matter in poor responders.
So
I don't.
actually, what we do actually in our clinical practice is that when I see that if I started with 225 or 200 recombinant FSH, and I see that on day 6, I've got a nice cohort around 12 to 14. I think this works better. And our basal LH, we know at times it is always better in these kind of patients,
The basic
because once you,
LH you are monitoring, Dr. Renu, but after 5 days, you will always find a LH which will be going higher now, no, with the stimulation.
yeah, we know, but you're adding NTAG as well, Neeti. So
Yeah,
it's a
yeah.
very difficult kind of, because when you add LH, the antagonist, the LH also suppresses a lot. At times you have to give some minute LH, so there is a discrepancy. So it depends. There is no distinct debate on this. At times people have continued with the same recombinant as well when the LH is, that is, the LH is normal, maybe around 5 on day 2 of the cycle. So there is, everybody can
Yeah.
take it. Maybe they can just add 75 LH and then decrease the dose of FH and make it 225 HMG also. So there's a debatable issue. That has to be seen on day 6, how well the follicles have been recruited.
Yeah.
So that's it. So regarding this Cochrane review regarding the output regarding the live birth rate, this has been published in 2024. And what did they see is that they had taken the MHS 21 picomole, that comes somewhere between 5 nanogram, because if you convert into nanogram per deciliter, and AFC as 14, this is they had taken as hyper responders in this Cochrane review. And they said that they had taken the 2 doses, 150 versus 100, and they said that live birth rate did not matter in these kind of this thing, and there was no significant difference in the live birth rate whenever the dose was 150 or 100. Regarding the OHS, they also said it was lower with the, obviously the 100 international unit of gonadotropin is compared to 150, but not significant difference. And regarding 150 clinical pregnancy rate also, they said it was not much of difference regarding whether you take 150 or 100. That was the inference of all this Cochrane review which had taken place. So my last question is, does age affect the dosing of gonadotropin? Nymphia.
You had already shown the normograms.
Yeah.
The
But
normograms
what do you do in your clinical practice? If she
yes.
comes like 35, do you change or do you think it will help something?
No,
Do you increase the dose?
because we had already discussed that, because when we are deciding the dose, age is definitely on our mind.
Yeah.
But if there might be a PCO who has a very high volume ovaries at 35, but here my mind will not go into a dose of 150. Probably I'll start at a dose of 200. And as far as that question of LH was concerned, like we also do an FSH LH on day 2, in such a patient, adding an LH sub point of time would be on my mind, because the age factor is there. So if we have starting a lower with the FSH LH ratio where the LH is lower on day 2, or I see a discontinuous follicle, some after 4 or 5 days of stimulation, that some follicles are growing very well. And in this particular patient, if the age is 35, then adding an LH at some point of time would be on my mind.
Okay, thank you. Umesh, madam, do you want to say anything on this? What is your clinical? I think you have a very vast experience
We
regarding all age groups.
usually giving LH in all patients in later half, day 5.
Okay. Not on the day 2, madam?
Not day 2, not all patients.
Okay.
Some patient you might give, but not
There's a good AFC not.
give, but not hyper mein itna nahi.
Okay.
I think
So
Raju-
regarding, this was
Raju
a paper which is published regarding the prediction of antral follicle outcome. They had taken the FC, the threshold combined with female age, female causes of infertility, and ovarian response in a prospective cohort of 8,269 women. And then they had seen that if the AFC was lesser, obviously the clinical pregnancy rate was lesser. But once the threshold was somewhere between 12, 13, just see the clinical pregnancy rates remain somewhere between 30% and 35%. So that we all know. And regarding the predictors and clinical outcome, according to the FC quarantile, I think age, duration of infertility, all causes of infertility like PCO, all play a major role. That was the study which they had told. And even the FC more than 18, they said all these factors do play. They are the good predictors where you can decide the clinical outcome for the patients. And regarding the age, just see the bars, they are the age group. Just see whether the FC is more than 18 or whatever it is, the FC is 1 to 5. If the age is higher, even the preclinical pregnancy is lesser in these kind of patients. So even if you take a more than 18 count, if the age is greater, even the clinical pregnancy is late. All these bars are the age factors which are different age groups, and then they had compared regarding with the AFCs and the clinical pregnancy rate. So just to conclude, I think we have all finished with this, and it was a very good discussion with all of you. Just to summarize, AFC values and AMH can be used for planning the gonadotropin dosing, the regimen, and the trigger strategies. AFC can also be used as a predictor of OHS. Increased AFE count is not associated with increased cumulative live birth rate, and pre-treatment discussion with patients regarding the possibility of fesol cycle is advised to ensure patient safety care, and proactively using these markers allows for more personalized treatment approaches. And I thank you all my panelists, Neeti, Nymphia, Umesh Madam, and Dr. Raju, for such a nice interaction, giving your experience, whatever you do in your clinical practice. Thank you so much.
Thank you, Dr.
Thank
Dipti.
you.
Thank you, Dr.
Thank you.
Dipti.
Thank you, Suveen, for inviting us.
Thank you so much.
And I'd especially like to thank Raju, who's the chapter secretary of Kerala, and Ruchika, who's the chapter secretary of UP West, to join hands with us. Thank you so much. It was a pleasure being with you. Renu, would you like to just thank everyone?
Yeah, I would like to thank everybody. I think Ruchika, Dr. Ashok Khurana for making such a good presentation about AFC count, Dr. K.D. Nair, Dr. Umesh, all of you who have joined us with this and giving your superb time. And it is a very nice interaction. Thank you so much. And I thank all the delegates. I thank Atul for being with us on this webinar, for helping us out with all that. Thank you so much,
And
Surveen.
Akanksha for being the MC. Thank you.
Yeah, definitely. Not to forget that. Thank you, Akanksha.
Thank you, ma'am.
Ma'am, I want to congratulate you
Good
on
night.
holding these webinars, these short ones. And it was such a good thing to have 4 panelists discussing, and a very nice
Yeah.
discussion session.
There could be a lot of experience sharing with just 4, otherwise when there are too
Yeah.
many, that experience sharing doesn't come.
And on a very, very focused, only antral follicle count, you took a very nice way of having this webinar. Congratulations, really.
Thank you.
Thank you so much.
Thank
I think so.
you.
There's one question, Surveen, ovarian volume and role of stromal blood flow. Does it have any role? I think so. Nobody's talking about ovarian volume. That is also Dr. Ashok Khurana said. So we are not taking that into
I
consideration.
don't think that has any role, because
Yeah.
it's a small ovary and it has many follicles. It's going to stimulate.
Yeah.
Like a hypo ovary often is very small, but the antral
Yeah.
follicle count is there and they stimulate well. I don't know about stromal blood flow. Anybody wants to comment? Raju, do you look at it?
No, ma'am, not at all.
Not at all. Okay.
Okay.
Thank
Thank
you.
you so much.
Thank you. Thank you.
Thank
Have
you,
a
ma'am.
great day,
Thank you,
everyone.
Nymphia. Thank you so much.
Thank you.
Thank you, Dr. KD.
Thank you, sir, for being with us all the time. Thank you so much, sir.